Now, the process of drug development involves a series of controlled trials. Okay? So there's preclinical testing, and then there's clinical testing of drugs. Okay? And the gold standard for clinical trials or clinical testing of a drug is what's called the randomized control trial. Okay? And even more so, what's the gold standard is what's called a double-blind randomized control trial. Okay? And now what a double-blind control trial means is whenever you're doing a testing on a drug, you have to have a control group, which means that you have to have a group that's actually getting your drug, and then you have to have a group that's getting fake drug, right? Something that's a placebo. And those two groups have to be very similar. Okay? They have to be very, very comparable in terms of composition of males to females, in terms of age, in terms of comorbid conditions. Okay? And usually for drugs that are being tested, the control group is not getting no treatment, because that's unethical. What they're getting is standard treatment. Okay? So you have two populations. One population's getting the standard care, and the other is getting the new drug. Okay? Now, randomization means that for every patient enrolled in the trial, it is completely random whether they are assigned to one group or the other, whether they are in the control group or in the intervention group. Okay? That's the randomization. And then blinding means that a blinded trial means that the subjects don't know which group they're in. Okay? And double-blinded means that both the subjects and the researchers don't know what groups the people are in. Okay? And that's really the standard for evaluating the effectiveness of a drug compared to standard treatment. Okay? And sometimes what you hear is that a clinical trial will be stopped in the middle of it because the intervention group, the new drug, was proven to be so much better than the control group, or either no treatment or the standard treatment. And so if it's very, very obvious that the intervention group is doing far, far better, it's actually unethical to continue the trial. You have to stop it and offer it to all the patients. Okay? And interestingly enough, there was a trial that was done on the Mediterranean diet, or a study done on the Mediterranean diet, and they had to stop it in the middle because the patients on the Mediterranean diet did so much better than the patients on a standard diet that they had to educate the rest of the population, or the group. So, Mediterranean diet, go for it. When we're talking about developing new drugs, like I said, we're talking about preclinical testing. So this is the laboratory testing. This is done in animals, okay? And what we're trying to evaluate is the pharmacokinetics and the pharmacodynamics, okay? We're trying to evaluate the dose responses. So as you increase the dose, what is the response with respect to the therapeutic response, and what is the response in terms of the toxic responses. Okay? So you are actually intentionally giving very, very high doses in order to see what is the range where you start to see toxic effects, what's the maximum toxic effect. You're trying to evaluate all the different aspects of the drug that you wouldn't do in humans. Okay? So that's all preclinical testing. So we go into clinical testing knowing a lot about a drug that we have learned in laboratory tests. And then the clinical trial testing has different phases. So there's phase 1, phase 2 and 3, and phase 4. Phase 1 is the drug being tested on healthy patients. Okay? So these are volunteers. They're being compensated for their time, and the drug is tested on all the patients are healthy, and there's a control group and there's an intervention group, and it's double-blinded and the whole thing. Once the results of that are learned, you can move on to phase 2 and 3, and this is where it's actually now being tested on patients. Okay? And this is where you have standard care versus trial care, right, new drug, and we get information about that. And usually after phase 2 and 3, an approval decision is made. Okay? And if the drug is approved, it can move to market, and phase 4 is really post-market surveillance, okay, watching the effects as it's being applied to much, much larger populations. Okay? The rationale for testing on healthy patients is that you can evaluate a dose response. We're going to talk about dose response curves. That you can evaluate a dose response curve, because the drug is going to have a response in all patients. But a healthy patient is less likely to have adverse effects than the sick patient. So you're trying to see, for example, a drug that is, does a drug have some hepatotoxic effects? Okay, meaning does it impair liver function temporarily? Right. So you do that. You do a liver panel. You see the enzymes go up in a healthy patient. If that was a sick patient, it might have caused some serious damage. So it allows you to see a dose response curve in a patient that is less likely to have an adverse effect. Yes, exactly. And these are volunteers that have to sign an informed consent, where they have to be given all the information that's known about the drug and all the possible risks, any possible benefits, and they have to make an informed decision as to whether or not they want to participate in the trial. And there's actually a limit to how much you can pay participants, because it can be construed as exactly undue duress or whatever they call it. Yeah. I believe that phase, well, so the post-marketing surveillance is, all drugs are in the post-marketing surveillance. All approved drugs are in phase 4 all the time. That's right. That's right. And phase 4 includes, like, you have a physician who sees like an unusual effect on their patient, and they publish a paper on it. That's the database we're talking about. And then phase 2 and 3, there are databases of clinical trials that patients can actually search out and find, and to see, they're unsatisfied with their current regimen. They want to try an experimental treatment. So oftentimes the patients or the doctors are looking at these databases and seeing what their patients can take part in. Okay? And teaching hospitals or research hospitals have somewhat of a reputation for pushing their patients into trials. And so what you'll find is that if there's lots of research happening at a particular place, a patient is presented with more opportunities to participate in a clinical trial, because the clinical trial is happening at the institution. And that can be good or bad, depending on how you feel about it as a patient. There are obviously lots of limitations to the testing process, to the development process. And we mentioned this earlier, that it often excludes certain groups because of feared liability. So that includes, I mentioned children, but also women. A lot of what we know about some of these older drugs was tested in almost exclusively men, and almost exclusively middle-aged men, and almost exclusively white middle-aged men. So we're just starting to understand and appreciate that there are differences in lots of things, both in disease patterns and expression, but also in drug responses with regard to women and other groups besides middle-aged white men. And so women were specifically excluded from studies until the 1990s when drug developers were developing drugs. So also the testing procedure can sometimes fail to detect all the adverse effects, which is why it's so important, this post-approval surveillance. Now, drug names. Drugs have 3 names. They have a chemical name that is long and very complicated sounding. They have a generic name and a trade name. The chemical name is the actual chemical structure. There's a series of rules for describing the structure of molecules, and it actually describes the structure of the molecule. The generic name is the active ingredient in the drug, okay? The ingredient that actually is producing the therapeutic effect. And the trade name is a name that is made up by the manufacturer, the drug developer, and does not have to correspond at all in even sound to the generic name or chemical name. So which name is best to use, generic or trade? Now, the problem with generic names is that they tend to sound more complicated than the trade name, okay? But it is the more desirable name to use when referring to drugs. The problem with trade names is a single drug can actually have multiple trade names. And a drug company can make up a new trade name for every application that they have an approval for in terms of drug use. So, and U.S. drugs and drugs outside the U.S. may have different active ingredients. So the same trade name, but with different active ingredients. And products with the same trade name may have, oh, that was the same. So you can have the same trade name in this country as abroad, but completely different drug in terms of what's in it. Okay? So trade names are really problematic, even though there are lots of drugs that the trade name is very commonly used. Okay? But it's really important to be at least aware of what the generic name is. And that's particularly true when the patent has run out on a drug and there are lots of generic companies producing the generic form of the drug. Okay? So one example, we've got acetaminophen. The generic name for the chemical name is N-acetyl-para-aminophenol. Right? That's a mouthful. We don't want to say that very commonly. And the trade name, there's lots of different trade names for acetaminophen. The most commonly known is Tylenol. But it's only one of many trade names that apply to acetaminophen. Okay? So acetaminophen is the better way to refer to the drug because it tells you exactly what we're talking about in terms of the active ingredient. So very generally speaking, what's the nursing role in drug therapy? And it really depends on what level of nurse we're talking about. Okay? So the first level of nurse, the RN in the hospital, your responsibility is in administering and overseeing the administration of drugs that are prescribed by another clinician. Okay? So the first level of nursing professional is responsible for safe administration and evaluation of drug response. Okay? And the role of the nurse in drug therapy has changed over the years. And the change is towards more and more responsibility. Okay? You know that adage, with great power comes great responsibility? Well, with nurses, it's with moderate power comes enormous responsibility. Okay? But you have responsibility nonetheless. And the reason is that the nurse is really the last line of defense in drug therapy, right? You are the last person who can possibly do something if there's a problem with the drug, okay? So there's this this thing called the Bill of Rights, right, where the nurse has the responsibility to give the right drug to the right patient at the right dose, at the right time, with the right kind of assessments, okay, both pre-assessments and post-assessments, right documentation, right evaluation, right patient education, and the right of the patient to refuse care, okay? And this is a lot of responsibility, but it's absolutely critical. Now, just giving the drug and making sure it's the right drug at with the right patient, right dose, right route. So perfect administration is not the end of your job, okay? Because simply giving a drug and then turning around and that's it is not fulfilling all of your responsibilities in terms of drug therapy for that patient. Okay? There are proper delivery is absolutely critical, and it's first and foremost. But there are assessments that must be done before, sometimes assessments that must be done before the drug is administered, assessments that must be done after the drug is administered. There are non-drug interventions that need to be done to minimize adverse effects or maximize the drug's effect. Okay? If you're giving an anti-cancer drug, right, one of those anti-cancer drugs to a patient where the risk of infection is increased, it's your job to implement good infection control so your patient doesn't get sick. Okay? So, or if you're giving a drug, and this is actually a really big deal, even at your level of nursing student, if a patient is taking a drug, if you're giving a drug that causes what's called orthostatic hypotension. Have you guys heard that term yet? Yeah. So orthostatic hypotension means with a change in body position, your blood pressure goes down. Now, when your blood pressure goes down, if you're talking about a patient that stands up from their bed, their blood pressure goes down, they get dizzy, and they can fall. Patients, particularly elderly patients on drugs like this, are a safety issue. Okay? So these might be patients that have alarms on their beds, right? That when they try to get up out of bed, an alarm goes off because you want somebody to be there to help them to the bathroom or to whatever, to the chair, because they're at high risk for falls. Okay? Another example, patient post-op knee replacement. Prescribed heparin, which is a strong anticoagulant, to reduce the risk of DVT, which is, oh my God. Yeah, that's what it is. Deep vein thrombosis, thank you. So you're going to reduce the risk of DVT because they're on bed rest. They're not really moving around much, right? So you have sluggish blood flow in the lower extremities, and it can cause the formation of a blood clot. Okay? So you give them heparin to reduce the risk of DVT. What are we then going to be very careful to monitor for? Signs of what? Bleeding. Signs of bleeding. Patients on heparin, signs of bleeding. Okay? Antidote to heparin. Anybody remember that? Protamine sulfate, thank you. Antidote to heparin, protamine sulfate. You're going to have that on hand. You see any signs of bleeding, you're going to give them that antidote. And there'll be a standing order for that. That's not something you've got to, you know, come out of without an order. But this is part of this ongoing post-assessment. You give the drug, and then you monitor the patient to make sure that the drug is being effective and the patient is safe. So nurses and the healthcare providers must participate in a system of checks and balances designed to promote beneficial effects and minimize harm to patients. So if you guys have already been in the hospital, right? No, you haven't. Okay. So you guys are going to be in the hospital soon. And what you'll find is these checks and balances can seem so excessive, okay? Patient's got a wristband. You got to check the wristband every time you give a drug, okay? Check the drug against their chart, okay? And then check it again, and then check it again, right? Triple checking. And there's a reason why the systems of checks is so excessive, because in fact it's not excessive, and mistakes happen all the time. Deadly mistakes happen all the time, okay? Things like handwritten prescriptions are misread, right? That's a big deal, because have you ever seen a physician's handwriting? This is why we're moving towards electronic medical records, right? So the doctor's actually got to put it into a computer so it's easier to read. I heard a story when I was in nursing school about digoxin. So there's a couple of drugs that are kind of infamous because they tend to be more dangerous than your run-of-the-mill drug. And digoxin is one of those drugs that has a really bad reputation, but it's because there's a lot of problems, particularly in the population that it's given to. It's a heart failure drug, and it tends to be given to patients who are older. So digoxin is a drug that can cause changes in electrolyte balance and cause cardiac arrest, basically, if given too much. The drug toxicity is there's what we call a narrow therapeutic index, which I'll explain later. But there's a very small gap between the therapeutic dose and the toxic dose of the drug. So the physician wrote digoxin twice a day at whatever milligrams. Now, digoxin is a drug that you must do heart rate and blood pressure before you give it, okay? 3 shifts of nurses misread this note as 4 times a day. And none of them did their pre-assessment blood pressure, heart rate. So this patient was completely passed out by the time the mistake was caught. Luckily, they did not die, but that's very easily a horribly tragic error where all 3 of those nurses are responsible, okay? And the provider who wrote the shitty note, excuse my language, is not responsible, okay? Because they wrote in their terrible handwriting, but they wrote the right dosage. It was just administered incorrectly. And so it's one of those things where nurses lose their license over things like that. So the nurse must know what medications are appropriate for the patient, what drugs are contraindicated for the patient, and the probable consequences of the interaction between drug and patient. So the nurse is the last line of defense for the patient. It's ethically and legally unacceptable to administer a drug that's harmful to a patient, even though that medication was prescribed by a licensed prescriber and dispensed by the pharmacy. Okay? So a drug that is prescribed and dispensed by the pharmacy, if, for example, you have a drug that causes significant renal impairment, okay, or it's excreted by the kidneys, and you have a patient with greatly impaired renal function, if you administer that drug, it's your fault. It's your responsibility to know that this drug is inappropriate for this patient, even though the doctor made the mistake and then the pharmacy made another mistake, but you gave it to the patient. Okay? So you never administer a drug that you're not familiar with. Take a little break, you look it up, you make sure that it's safe and it's appropriate. Okay? Right? Be nice to your doctor, to your nurses. They keep the doctors from accidentally killing you. That is the truth. Yes, it would be human error. So, and this does happen. So, for example, you have somebody that comes in with a heart attack, right? And they're being treated at the hospital for myocardial infarction. But they have a history of renal impairment, right? Plus, heart attacks can actually further compromise renal function. So it may not be on, who's prescribing this may not be the patient's primary doctor, and may not be fully versed in their history, and may not have versed themselves in the history. Okay? And then the next line of defense should be the pharmacy, right? But if they happen to make that error, the last line of defense is the nurse. And make no mistake, if something bad happens to that patient, everyone will get in trouble, right? But you're not, as a nurse, you're not off the hook just because the doctor and the pharmacy made a mistake. That is a great question. What is the most tactful way? What I have heard is a tactful way is to say, can you just clarify this prescription in light of this patient's renal history? That you ask a question to the provider about the prescription and make sure that you include details that may have been missed. And they might say, yeah, I caught that, it's fine, this drug acts a little different than usual, and it'll be fine. But there are ways to delicately push back on certain orders. Yeah, you can actually document it. You don't document it and give the drug. If your concerns are not addressed, you document it and then you go to your supervisor. You go above you. But if your concerns are not addressed when you ask, you don't give the drug. Yeah. Yes, ma'am. This is a good question. So the question is when the provider is writing the prescription and the pharmacy is filling the prescription, is the patient history synced with that? Certainly the provider has the responsibility to be versed in the patient's history in order, particularly if they're dealing with a drug that we know there are some sticky issues with it, right? So the provider has a responsibility. It may not be synced in the EMR, but it's their responsibility to then open the EMR and find out what the patient's history is. The pharmacy will know, at the very least, what other drugs the patient's on. Right? So the pharmacy will know what other drugs the patient's on. They should be able to catch any adverse interactions, and conceivably a knowledgeable pharmacist should be able to say, this patient's on a couple of renal drugs, is this a problem, and then call the provider to make sure. Yeah. So it's always important to, when we talk about the nurse's role, to go back and review the nursing process. So the nursing process, or ADPIE, is the basis for how you operate as a nurse. And the elements of the ADPIE include assessment, diagnosis, right? After careful analysis, diagnosis, which is usually a nursing diagnosis, which is slightly different from a medical diagnosis, okay? A nursing diagnosis is usually focused on symptoms or the problem rather than the disease, okay? And the reason why a nursing diagnosis is different and it's focused on the problem is because it gives a little more direction about what your role in helping the patient is, okay? So a patient with who's having an anaphylactic reaction, for example, and they're getting swelling around their windpipe, will have what's called ineffective airway clearance. That's the nursing diagnosis, okay? So instead of it being anaphylaxis, right, is the diagnosis, it's ineffective airway clearance, which makes it very clear what your role is, which is to secure the airway, okay? So it's very problem-oriented, these nursing diagnoses. And it's based on a very good assessment of the situation. And then once you make a nursing diagnosis, you do some planning, and then you have an intervention that you implement, and then you evaluate you basically do another assessment. You evaluate how effective your intervention was, okay? Which might lead to another diagnosis or another intervention. So this is the nursing process. And drug therapy fits quite well into the nursing process and with some adaptations. So there's two major areas in terms of drug therapy that is relevant for the nursing role. And that's in patient care, right, in just the obvious, in administering drugs and caring for your patient, and also in patient education. The patient has a right to understand what they're being given, why they're being given it, what the desired effects are, and what some of the undesired effects may be, okay? And they have the right to refuse care. So patient education, and you are usually, as the nurse, the person giving that patient education. So you have to be versed in all of those things. So the nursing process, as looked at in terms of drug administration, includes pre-administration assessments. Had any of those nurses who thought that this patient should get digoxin 4 times a day, had any of those nurses done the appropriate pre-administration assessment, would have seen that the person's heart rate and blood pressure were bottoming out, okay? And they would have held the medication. So the appropriate pre-administration assessment should be done. The appropriate dosage and administration should be done. Evaluating and promoting the therapeutic effects, right? Is the drug being effective? And then what can you do to promote the effectiveness? Minimizing adverse effects, minimizing adverse interactions, knowing what drugs and foods should and shouldn't be given, making PRN decisions, managing toxicity. PRN decisions, we'll talk a little bit more about PRN, but there are some drugs that are given on an as-needed basis. So you have a standing order for a drug, and you give it as needed. So an example for this is an order for acetaminophen or Tylenol, PRN for fever. So you're going to monitor the patient's body temperature, and if it becomes elevated, you're going to administer the Tylenol or the acetaminophen. So PRN medications, probably the most common, are pain medications. And so your question about that when you do a pain scale assessment and and the person gives you a number, you have to take it for face value, right? Because pain is a subjective experience, and you can't tell what they're going through. Now, usually when you have a standing order for a pain medication, a PRN standing order, there'll be a limit to per hour how much can be given, or per several hours or something like that. So there'll be a range of how much can be given based on the pain scale. And if you've maxed out in that hour how much you can give the patient, then you do other things to comfort them and relieve their pain until there's another opportunity, enough time has passed that you can give them another dose. But particularly, you know, there's self-managed pain medication where the patient can press a button and they get a dose of pain medication. There's a ceiling to how much they can give themselves per unit of time. Was there another one up there? Or? Okay. Yep. You can't give a medication for any other purpose than what it's ordered to be given for. If they have pain, you can contact their provider and ask for something for pain because the patient's in discomfort. And you report their pain scale and all of that. Yeah. Okay? So the pre-administration assessments, you're collecting a baseline. You need it to both make sure, sometimes to make sure that the drug is safe to give, but also you want a baseline in order to know whether the drug is then effective afterwards, okay? So if a drug is being given for pain, you want to have a pre-assessment pain scale measurement, and then you can do a post-drug pain measurement so that you can see whether it's actually managing their pain. And also, part of this assessment is identifying high-risk patients. So looking at patients with liver or kidney impairment, different genetic factors, different drug allergies. Is the patient pregnant? There are certain drugs that are contraindicated in pregnancy. Is the patient an older patient or a younger patient? By virtue of age, the elderly and children are in special categories. Okay? And there are certain drugs that need to be given with particular care or not at all in those groups. And your tools for this assessment is a good patient history, physical examination, and any laboratory results that may be available. Okay? So certain drugs have more than one indication. So you may see a blood pressure medication on the patient's orders, but it's being given for a completely different reason. Okay? So it's important to be familiar with the drug, but also it's important to understand why it's being given in the patient. Okay? The dosage may be different depending on the indication for the drug being used. So for one particular indication, the dosage may be small. For another indication, the dosage may be large. Okay? So that's why it's important to understand why it's being given, among many reasons. Many drugs have multiple routes of administration, and what you'll find is the dosage is different depending on the route of administration. So that's why it's important to not only know the right drug, but the right dose and the right route. And then certain intravenous drugs can cause severe local injury to tissue. Okay? So understanding that certain drugs should not be given in certain routes, okay? Or else you may cause injury. So always read the medication order carefully, verify the identity of the patient, read the label carefully, verify the dosage calculation, okay, so that your med math, make sure it's correct. Implement any special handling of the drug that may be required. Is it light sensitive? Is it temperature sensitive? Is it time sensitive? Okay? And do not administer any drug if you do not understand the reason for its use. Okay? Make sure that you understand it before you're administering the drug. And then once it's given, we want to evaluate. Okay? We evaluate for the therapeutic response, which is one of the most important aspects of drug therapy, is making sure that the drug is actually doing what we want it to do, which means that you have to know the rationale for the treatment. In order to do the right evaluation, you have to know why the drug is being prescribed. And you cannot effectively evaluate a drug with multiple applications if the intended use is not known. Okay? If you have a drug that has lots of different applications, Nexium is a great example of this. Okay? Almost every patient seems to be on the little purple pill, right? Almost every patient's on Nexium. And that's because Nexium is a proton pump inhibitor. It reduces acid in the stomach. And it's given for a million different reasons. One of the reasons is pre-operatively, before surgeries, Nexium is often given because it has been shown to reduce the risk of aspiration pneumonia. Okay? So just in case some stomach contents get aspirated into the lungs, it reduces, if the acidity of that fluid is low, then it reduces the risk of pneumonia. So that's a crazy indication, right? It's not that the person's got ulcers, right? It's that it's a very particular use. So understanding why a drug is being given is important. Okay? Evaluating patient adherence. Okay? Or compliance or concordance, a couple of different words for it. So if you're evaluating the effect and you're finding that the drug is not having the effect, the intended effect, you have to ask, if the patient was self-administering the drug, did they actually take it? Okay? So evaluating patient adherence, and then if they're not adhering to the drug, understanding or taking the drug, understanding why, so that you can have a conversation with them to impress on them the importance of taking it. And then implementing non-drug measures that enhance the effectiveness of the drug. Drug therapy can often be enhanced by lots of these non-drug measures, like biofeedback, emotional support, smoking cessation counseling, sodium restriction, and lots of others. For example, that hypertension case that I talked about earlier, where a patient doesn't feel sick, but they take medication and it has some side effects. If you tell a patient with high blood pressure to take their blood pressure every morning, that actually has a bit of a biofeedback effect where it can lower someone's blood pressure to the same degree as a drug. Right? So just having your patients take their blood pressure every morning actually can lower their blood pressure and greatly aid in the effectiveness of the drugs that they're taking. So that's a non-drug measure that enhances the effects of a drug. And then minimizing adverse effects. All drugs have potential to produce undesired effects. So you always want to know the major adverse effects the drug can produce, okay? The times when these reactions are likely to occur. Is this something that's likely to occur at the beginning or likely to occur after a while of use, right? Early signs that an adverse reaction is developing, and interventions that minimize discomfort or harm, okay? So understanding these adverse effects so that you can be on the lookout for them, understanding the difference between adverse effects that are just kind of annoying but benign, and ones that actually have great potential for harm. Okay? Taking a thorough drug history, understanding what drugs patients are taking, And I'm going to say this, and I can't stress it enough, especially over-the-counter medication. Okay? Dietary supplements, vitamins, things that they're taking, herbal medications. These are not things that are going to be on that little sheet that they give you with all their drugs, right? But if you find out they're taking, for example, St. John's wort interacts with a whole slew of drugs and can lower the effectiveness of it and change the dosage that is actually makes it to the site of action. Yes, ma'am? So it's a good question that taking your blood pressure every morning, is it placebo or is it an actual effect? Whether they know that it'll work or not, it'll work. And there does seem to be some kind of biofeedback mechanism, but there's also this thought that just that being aware of their blood pressure has slight effects on their behaviors. So they're a little bit more likely to adhere to the low-sodium diet or to exercise a little bit more, right? So there's it's a lot of different things that contribute to that effect. So take a thorough drug history, including over-the-counter medications. Okay? Advise the patient to avoid over-the-counter drugs that can interact with prescribed medications. Monitor for adverse reactions that are known to occur. Okay? And there are interactions that can occur between foods and drugs. Right? There's lots of cardiovascular drugs, whether it's lipid-lowering drugs or blood pressure medications or heart failure drugs, where grapefruit juice changes the levels of those drugs. Right? So like most adults, you'll find, are avoiding grapefruit juice because by the time you get to middle age, the likelihood of being on one of those drugs is actually kind of high. And then this PRN order, making PRN decisions. PRN stands for pro renata, which means as needed. So the nurse has discretion, a certain degree of discretion, regarding how much of the drug to give and when to give it. And the criteria for making that decision is provided by the prescriber. Okay? So a PRN drug can be given, as I said, based on body temperature, based on pain scale, based on blood pressure, based on heart rate, based on any number of clinical pieces of data. But it's either going to be administered or withheld depending on that criteria. Okay? Now, managing of toxicity. So managing toxicity, number one, is we want to avoid toxicity. And number two, we want to, at the very least, catch it early if it is happening. Okay? So we want to, early identification makes interventions more possible, and you avoid harm the sooner you catch toxicity. Now, in terms of patient education, everything that you've learned about the drug is part of patient education. It may not all be things that the patient needs to know, but the patient certainly has the right to know what they're taking, how much of it they're taking, how often, how they're going to take it, the route of administration, what response, why they're taking it, what is the therapeutic response, and then what can they do or you do together with them to enhance the therapeutic response. Okay? So lots of drugs, having the patient's participation can actually maximize the effect of the drug. It's also important for patients to understand how long they'll be taking it, if they're taking it on their own, and there's special instructions for drug storage, making sure they understand that. making sure if they're going home with a drug, making sure they understand adverse effects and early signs of adverse effects. Okay? They should understand major adverse effects and major drug-drug and drug-food interactions, and who they should contact if they find that the drug is not working or is causing unwanted effects. Okay? And some drugs may have effects that are seemingly benign, but are actually signs of a true adverse effect. An example of this are ACE inhibitors, very common drug for heart disease. And ACE inhibitors, in some people, cause a persistent cough. And a patient, unless they know that that can happen, may not attribute the cough to the drug. But if a patient develops a cough on an ACE inhibitor, they need to be given a different drug because it represents an adverse effect. Okay? So good patient education allows for more successful drug therapy. When drugs are approved by the FDA, I talked about this last time, after they are approved by the FDA, they are then take part in this post-approval surveillance period, right? And part of the post-approval surveillance period is reporting of adverse effects or adverse events. Adverse drug reactions, we've got known adverse drug events, and when one of these events happen, we report them so they can be part of that post-surveillance. But we also have medication errors, which is not a part of the drug's adverse event. That is actually an adverse event that happens because of an error in medical care, okay? Which is usually human error. Now, adverse drug reactions can be mild. They can include things like drowsiness, nausea, itching, or a rash. Or they can be much more severe, respiratory depression, neutropenia, which is a drop in neutrophil count, which compromises immunity, hepatocellular injury, so liver damage, anaphylaxis, hemorrhage. The elderly and the very young are the most vulnerable to adverse events, okay, or adverse reactions. Because as people age, liver function changes, renal function changes, so their ability to metabolize and excrete drugs become compromised. And the same thing with young patients. Their kidneys are immature, their livers are immature, so they have a limited ability to metabolize and excrete drugs. Okay? And in the severely ill, the risk also increases. So terms that are related to adverse drug reactions, a side effect is an effect that we often see with a drug, commonly see with a drug that is undesirable and not part of the therapeutic effect. Toxicity has to do with the effects that we see when the drug levels get above the therapeutic range. Allergic reactions, patients sometimes have allergies to particular drugs, and allergic reactions tend to, they can happen locally with redness or swelling, irritation, itching. They can be more systemic. They can look like hives, or they can be very life-threatening and involve anaphylaxis. Okay? Idiosyncratic effects are effects that are not harmful or necessarily negative, but they are unexpected and unintended. Paradoxical effects are effects that are opposite to what you expect. Okay? And I was talking about this last time, that particularly with children, sometimes stimulants will act like sedatives, and sedatives will act like stimulants. So you can see paradoxical effects in certain cases. Iatrogenic injury or disease is injury or a disease that is caused by medical care, okay? Unintendedly caused by medical care. So if we give a contrast dye in the course of a catheterization, and that contrast dye is damaging to the kidneys, and we push the person into kidney failure, that kidney failure is iatrogenic. Okay? So, or if someone acquires an infection while in the hospital, that is a nosocomial infection, which is an iatrogenic disease. Yes, ma'am?
Is a medication error an iatrogenic?
Yes, yes, yes. Physical dependence. Physical dependence, actually, there is a fairly narrow definition for physical dependence. And it has to do with when someone is on a drug, the body reduces the expression of the endogenous ligand. Okay? So when someone takes a drug and the body reduces its production of the endogenous ligand, you become physically dependent on the drug. Because in the absence of the drug, what you experience is withdrawal. Okay? So physical dependence is different than addiction, because addiction has a much wider definition. Okay? Physical dependence really means that in the absence, you experience withdrawal because the endogenous ligand has, and the receptors have changed. Okay? Carcinogenic effect. A carcinogenic effect means that the drug in question can cause the development of cancer. Okay? So carcinogenic drugs are drugs that can cause damage to cells at the DNA level and produce cells that are cancerous. And teratogenic effect. A teratogen is anything, if introduced during pregnancy, can cause birth defects. There are drugs that have, often with their toxicity, the toxicity is very organ-specific. Okay? So common examples include what are called nephrotoxic drugs, or drugs that can cause damage to the kidneys. An example is amphotericin B, which is an antifungal medication. Okay? But huge categories of drugs are nephrotoxic or have different degrees of nephrotoxicity. Okay? So the kidneys can be vulnerable to damage. The heart, especially affecting the conduction system in the heart. And we'll look at that in a second. But drugs can sometimes cause dysrhythmias, which can lead to cardiac arrest. You have drugs that can affect lung function, can cause damage to the lungs, scarring of the lungs. You have drugs that can affect the inner ear, which we call, ototoxicity, thank you. So ototoxic drugs can damage the inner ear and cause hearing loss. And younger patients tend to be a lot more vulnerable to ototoxicity, particularly because their ears are still developing, the sense of hearing is developing. We also have the lots of drugs that have relative levels of hepatotoxicity, which is damaging to the liver. And then we have drugs that affect the heart in a very particular way, and that's by affecting the QT interval, which is the time between the Q wave and the T wave in the EKG, which can cause a very particular kind of dysrhythmia. So hepatotoxic drugs is the leading cause of liver failure in the United States. More than 50 drugs are known to be hepatotoxic. Some drugs undergo metabolism, and then the metabolites are actually toxic to the liver. This is actually what happens to with alcohol. When we drink alcohol, it's actually metabolized by the liver, and it produces something called acetaldehyde, which is hepatotoxic. So the liver kind of gets punished for doing its job in that case. Combining hepatotoxic drugs can increase the risk for liver damage. Taking Tylenol or acetaminophen while drinking is an example of that. Monitoring liver enzymes, AST and ALT, which stand for aspartate aminotransferase and alanine aminotransferase. These enzymes are found, these are enzymes involved in the filtering function of the liver. They're found inside of the liver cells. So when the liver gets damaged, they get released, absorbed by the blood, and so the blood levels of these enzymes increase. Okay? So we can monitor these enzyme levels when a patient is on a hepatotoxic drug in order to make sure that we're not causing liver injury. And we can watch for signs of liver injury and educate our patients about signs of liver injury. Number one thing that hallmark sign of liver injury is jaundice, or a change in the color of the skin, or the whites of the eyes, hands, palms of the hands, soles of the feet, turns a bit orange or yellow, dark urine, light-colored stools, nausea, vomiting, malaise, abdominal discomfort, loss of appetite. These are all signs of liver injury. Okay. Any patient with known liver dysfunction either should be not put on a hepatotoxic drug or monitored very, very closely if they have to be on a hepatotoxic drug. More than 100 drugs are known to change the QT interval. And what tends to happen with the QT interval is that it tends to get longer. And that can result in really life-threatening arrhythmias. So the QT interval is the measurement of time required for the ventricles to repolarize after every contraction. And the QT drugs are drugs that can prolong the QT interval and can create really life-threatening dysrhythmias. Minimizing the risk. Most patients are at high risk, including women, older adults, and patients with bradycardia, congestive heart failure. If they have congenital QT prolongation, meaning they already have a prolonged QT interval, they're at very high risk. Low potassium or low magnesium. And the rule of thumb is to avoid using two drugs at the same time that both elongate the QT interval. Okay. And just to remind you, this is what the EKG looks like. The Q wave is right here. The T wave is right here. The QRS complex is the depolarization of the ventricles, and the T wave is the repolarization of the ventricles. So it's within this time frame with the QRST that the ventricles are both contracting and relaxing and filling. So because this part of the EKG has to do with ventricular electrical activity, dysrhythmias in that part of the EKG are the most life-threatening. Ventricular dysrhythmias are the most life-threatening. So it's a very serious problem. I saw a hand. Yeah.
So what would make a provider prescribe
didn't hear that last part. What would make the provider prescribe both would be maybe a low-risk patient and two drugs that are very difficult to swap out with other drugs. So the risk of treatment is less than the risk of no treatment. That would basically be the deciding factor. And then medication errors. Fatal medication errors generally tend to be in the form of overdoses. Okay? So giving a drug that either objectively in all people represents an overdose or in a particular patient represents an overdose, okay, because of impaired renal function or impaired liver function or taking a concurrent drug that has the same effect. Wrong drug, 16%, wrong route, 10%, right, or 9.5%. So lots of different forms of medication errors, but these are just fatal medication errors. Causes of medication errors, most of the time, the majority of medication errors are human errors. And they include basically human factors. So you're distracted that day, you're stressed out that day, you have something going on and you're not you're not paying attention. We have communication mistakes between providers. I described the physician that wrote the digoxin prescription, and everybody read it as 4 times a day rather than twice a day, right? So communication mistakes, drug name confusions. There's lots of drugs that have very similar names, and giving the wrong drug actually is a catastrophic mistake. Okay? So 90% of all errors really fall into this category. So ways to reduce medication errors. And I can't really actually stress this enough, is basically getting the patients involved in their taking of their medication. So explaining to them what they're taking, how much they're taking, how often they should be taking it, because just because you're going to provide it safely on your shift doesn't mean that the next nurse is going to do that. But if the patient sees a pill that they're not used to seeing, or at a time they're not used to seeing it, they're going to question it, and it's going to be less likely that the error is going to happen. Okay? Institutionally, there's a lot that can be done to prevent medication errors. A lot of safeguards that have been put in place, particularly in the last 20 years, or even the last 5 years. And there are certain drugs that fall into high alert drugs. There's about 20 of them that cause about 80% of medication-related errors. So more provider education and education at the nursing level about those drugs, alerts that can come up when you are giving those drugs or get an order for those drugs. So there's a lot that can be done in focusing on those 20 drugs that cause those errors. And then the switch from handwritten orders to computerized orders has reduced medication errors dramatically, increasing the competence of pharmacists. So when you go to the hospital, there's almost always a PharmD in that pharmacy, and a PharmD that often rounds with physicians. So a doctorally prepared pharmacist who's really versed on how drugs can interact with different disease states and different individuals has reduced medication errors dramatically. Barcode systems that ensure that the right drug and the right patient are coordinated avoiding error-prone abbreviations, and performing medication reconciliation, which basically means you get a list of medications that the patient should be on, and you reconcile that to the list that maybe the patient comes in with to make sure that there aren't differences or there aren't drugs that they should be taken off of, and then permanently changing the record when you find errors in that reconciliation. Okay?